Alright, we are going to go over the urinary tract, and this again is one of the lectures in the series of abdominal sonography. So, we're going to go over the anatomy of the kidneys, the ureters, and the bladder, as well as pathology, and we're going to look at some vascular anatomy and some renal vascular complications and basic transplant assessment. There's some key terms here, and when I send you the file you will be able to search for the definitions of these to supplement your learning. But I might go over a few of them. For example, azotemia is an excess of urea or other nitrogen compounds in blood. Blood urea nitrogen is a measure of the amount of nitrogen in the blood in the form of urea. Amyloidosis is an accumulation of abnormal protein amyloid in the kidneys. Mural nodules are small masses located on the wall of a structure. Nephrotic syndrome is a kidney disorder caused by damage to the glomeruli that results in excess amounts of protein in urine and the swelling of the ankles, the face and the feet, because there's accumulation of excess water. A neurogenic bladder is a bladder that is poorly functioning, secondary to any type of neurologic disorder. So we can come to the anatomy and physiology of the kidney. And so the urinary system consists of an upper urinary tract, and the upper urinary tract is formed of the kidneys and the ureters, and we have a lower urinary tract that is composed of the bladder and the urethra. The functional unit of the kidney is the nephron, and the nephron begins to function by the 9th week of gestation, but urine production can occur between the 11th and 13th week of gestation. The functional urinary tract is important to the fetus because the urine produced by the fetal kidneys comprises majorly of amniotic fluid. Fundamentally, the kidneys are organs that are vital for homeostasis, and kidneys detoxify and filter blood, they excrete metabolic waste, and dynamically resorb amino acids, iron, glucose, and water, and they also maintain normal pH. They absorb iron, and they maintain salt levels in blood. The kidneys also work to regulate blood pressure by producing the enzyme renin. So embryologically, the kidney is formed when two embryonic parenchymal masses combine, and these two masses are referred to as ranunculi or renunculi, and the kidneys initially develop within the pelvis, and they ascend into the fetal abdomen by the 12th week of gestation. And this is one of the explanations for ectopic kidney locations, such as a pelvic kidney, which is the most common location for an ectopic kidney. However, this ascension can be arrested anywhere along this migratory path. Adult kidneys are bean-shaped, and they are retroperitoneal in location. The left kidney is generally higher than the right because of the size of the liver, and the liver occupies most of the right upper quadrant of the abdomen, and this pushes the right kidney lower. The left kidney is also on average a little longer than the right, although typically we are looking for no more than a 2 centimeter difference between kidney lengths. However, suspicion of functional renal abnormalities may abound if there's a difference in excess of 2 centimeters between the two kidney lengths. The coverings of the kidneys are indistinguishable, or this renal capsule is indistinguishable on a sonogram. And we have a pararenal fat layer which covers Gerota fascia, and an additional fat layer known as the perirenal fat layer. The innermost covering of the kidney is the renal capsule, and more superficial to the renal capsule is the perirenal fat layer. And now these layers protect the kidney and act as shock absorbers. And the kidney is made up of two parts. It's made up of a renal parenchyma and a renal sinus. And the parenchyma of the kidneys consists of the renal medulla and the renal cortex. And the renal medulla, or rather the inner part, is responsible for absorption. And this includes the renal pyramids, the renal cortex, and these filter blood. And the renal sinus contains the renal collecting system, and it is composed of minor calyces, major calyces, the renal pelvis, and the infundibula. The renal pelvis is a funnel-shaped structure that collects urine before it moves on into the ureter. Renal arteries are branches of the abdominal aorta, and these are located inferior to the superior mesenteric artery. Oxygenated blood travels through the renal arteries and enters the renal hilum, and then in the segmental branches it divides, and it subsequently further divides into interlobar arteries. And these interlobar arteries can be noted traveling between renal pyramids. The interlobar arteries branch into much smaller arcuate arteries at the base of the renal pyramids, and the arcuate arteries then branch into the interlobular arteries, and into what we know as afferent arterioles. And these afferent arterioles carry blood into the glomerulus for filtration. The right renal artery travels posterior to the inferior vena cava, and the right renal artery is therefore longer than the left renal artery. The renal vein exits the kidneys at the renal hilum and connects to lateral aspects of the IVC. The left renal vein has to travel across the abdomen between the superior mesenteric artery and the abdominal aorta. It is therefore longer than the right renal vein, and it is normal for the left renal vein to be smaller in diameter as well. So just to reiterate the oxygenated blood flow. So blood flows down through the abdominal aorta into the renal artery branches, and then the renal arteries enter the renal hilum. From the renal hilum, blood subsequently enters segmental branches, then interlobar arteries, and finally it enters arcuate arteries. And arcuate arteries finally branch into interlobar arteries, and then they branch into afferent arterioles, which carry blood into the glomerulus for filtration. Alright. Here we have an image of the kidney. We can see the renal pelvis, the renal sinus, the ureter, the renal vein and the renal artery, the renal hilum, cortical substance, medullary substance, minor calyces, major calyces, interlobar arteries, interlobar veins, nephrons, renal capsule, and so on and so forth. So there are certain laboratory tests we can used to test the function of the kidneys. So we can look for bacteriuria, pyuria, hematuria, and proteinuria, and blood tests may be used to analyze the levels of blood urea nitrogen, creatinine, glomerular filtration, and lactate dehydrogenase. Creatinine, also excreted by the kidneys, measures the amount of creatinine phosphate found in skeletal muscles. So if we look at these blood tests here, blood urea nitrogen, if it is elevated, is associated with renal failure, a renal parenchymal disease, renal obstruction, some form of hemorrhage, diabetes mellitus, and dehydration. A reduction of blood urea nitrogen is associated with liver disease. Creatinine increases are associated with renal failure and chronic nephritis. The glomerular filtration rate, if it is normal, is between 60 and 90, but no less than 30. Lactate dehydrogenase increases indicate renal infarction or chronic renal disease. Total white blood cell count is an indicator of inflammation, and hematocrit is an indicator of hemorrhage. So the sonographic appearance of the kidney differs with age, and multiple variations may be noted. Normal adult kidneys are elliptical in shape in the longitudinal plane, and they are rounded in the transverse plane. Though renal size varies with age, in the adult they typically measure 8 to 13 centimeters in length, 2 to 3 centimeters in the AP dimension, and 4 to 5 centimeters in width. The renal sinus is central in the kidney and has an echogenic appearance. The renal cortex appears as medium to low-level echoes surrounding the central sinus. The normal cortex should be more hypoechoic or isoechoic to the liver or the spleen, and it should measure more than 1 centimeter in thickness. Echogenicity of the kidney are as follows. The renal medulla is hypoechoic to the renal cortex. The renal cortex is hypoechoic or isoechoic to the liver. So there are certain congenital anomalies of the kidneys. Compensatory hypertrophy is enlargement of the unaffected contralateral kidney with unilateral renal agenesis or compromised renal function. Dromedary hump, bulge in the lateral border of the kidney, is seen as the same echogenicity as the adjacent renal cortex. A duplex collecting system is a variant in where there are two separate renal sinuses, and these are referred to as an upper pole moiety and a lower pole moiety. Obstruction to either one of these can occur, and we have two ureters that are draining separate portions of the kidney. And a kidney with a duplex collecting system will typically measure longer than a normal sized kidney. An ectopic kidney or a pelvic kidney is a kidney in which its location is within the pelvis. and the pelvis is the most common site of ectopic kidneys. Cross-fused ectopia, this occurs when both kidneys are fused on the same side of the body. A thoracic kidney is a kidney that sits partially or completely within the chest. The extrarenal pelvis is a renal pelvis that is located outside of the renal hilum. Fetal lobulations are lobulated or bumpy outlines to the kidneys, and they can also be seen in adults. Horseshoe kidneys are kidneys that have crossed the midline and connected their lower poles by an isthmus, and the isthmus travels anterior to the abdominal aorta and the inferior vena cava. A hypertrophic column of Burton is an enlargement of a renal column, seen as an indentation of the renal sinus. A junctional parenchymal defect results from incomplete fusion of the two embryological components of the kidney, or ranunculi, and it appears as a wedge-shaped structure on the interior portion of the kidney, located between the upper and middle sections of the kidney. A mild rotated kidney is a kidney that sits in the renal fossa, but is positioned off the normal axis. Renal agenesis is a congenital absence of a kidney, and it is important to note that bilateral agenesis is typically not consistent with life. Renal hypoplasia is an underdevelopment of the kidney, in which there are too few nephrons, and the kidney is smaller than normal. Renal sinus lipomatosis is excessive fat within the renal pelvis, and a supernumerary kidney is a third smaller kidney. So we can have acute renal failure, and this is a sudden decrease in renal function, typically over the course of a few days or weeks. We term it acute due to its sudden onset, and its most common cause is acute tubular necrosis. In acute tubular necrosis, the kidney suffers from ischemic damage and subsequent cell destruction. Other causes of acute renal failure include renal artery stenosis, renal infection, UTIs, polycystic kidney disease, metabolic disorders such as amyloidosis, and inflammatory conditions such as Henoch-Schönlein purpura. And Henoch-Schönlein purpura is an autoimmune inflammatory vascular disease that mostly affects children, and it can permanently damage the kidneys. Clinical findings of acute renal failure include oliguria, hypertension, leukocytosis, hematuria, edema, and hypovolemia. Sonographically, the kidneys may appear normal, or they may have some echogenic structures, and hydronephrosis may be present. So we can also have a gradual decrease in renal function over time, and we refer to this as chronic renal failure. Kidneys that fail to function normally will lead to end-stage renal disease, and the most common cause of chronic renal failure is diabetes mellitus. Other causes include glomerulonephritis, chronic pyelonephritis, metabolic disorders, among others. Clinical findings include malaise, elevated BUN and creatinine, fatigue, hypertension, and hyperkalemia. Sonographically, we see small echogenic kidneys, cortical thinning, and loss of normal corticomedullary differentiation. So here is an image of chronic renal failure. The kidney between the calipers is significantly more echogenic than the adjacent liver parenchyma. The kidney is also reduced in size, and there is loss of the normal corticomedullary differentiation. Renal cystic disease. So we can have a simple cyst, which is one of the most common renal masses. And a simple renal cyst should appear sonographically as an anechoic mass that is spherical, has smooth walls with posterior acoustic enhancement, and no internal echoes. An anechoic mass that does not meet this criteria is not considered a simple renal cyst. Clinically, patients are usually asymptomatic, and sonographically, we find a spherical anechoic mass with smooth walls and no internal echoes and through enhancement. Complex renal cysts. These are cysts that do not meet the criteria of a simple cyst. And it is important to note that renal cell carcinoma may manifest as a multicystic mass. Therefore, when a cyst has certain characteristics such as internal debris, mural nodules, papillary projections or internal borders, and septations, we begin to worry about malignancy. Autosomal dominant polycystic kidney disease. This is a hereditary disorder and may be referred to as adult polycystic kidney disease, and it can lie dormant for many years. Often, patients are asymptomatic until the third or fourth decade. Patients come in with decreased renal function, urinary tract infections, renal calculi, flank pain, hematuria, and palpable abdominal masses. Sonographically, we see bilateral enlarged kidneys that contain numerous cortical renal cysts, and we can see possible cysts identified in the pancreas, the liver, or the spleen. So we can classify certain renal cysts. So renal cysts with internal calcifications present as posterior shadowing from the calcification within the cyst. Hemorrhagic cysts are usually anechoic, depending on the stage of hemolysis. Infected renal cysts have internal debris and thick walls. Milk of calcium cysts show a fluid level within the cyst, and there is shadowing and layering within the cyst. Multilocular renal cysts have thin septations separating fluid locules, and there's no blood flow. So this is an example of autosomal dominant polycystic kidney disease, and you can see multiple cysts within the kidney in the parenchyma. Autosomal recessive polycystic kidney disease is hereditary as well, and it is characterized by dilation of the renal collecting tubules. This is often recognized in fetuses and can be confirmed with a postnatal sonographic examination. Clinical findings include renal failure or abnormal liver function tests. Sonographically, we see bilateral enlarged echogenic kidneys and loss of corticomedullary differentiation. Multicystic dysplastic kidney disease is thought to be caused by an early or first trimester obstruction of the ureter. There is typically no normal functioning renal tissue present in the kidney that is affected by this, and if this condition is bilateral, it is fatal. Clinically, patients may be asymptomatic, and it may be an incidental finding, but it can be identified by several smooth-walled, non-communicating cysts of varying sizes in the area of the renal fossa, and these completely replace all renal parenchyma. And if it is unilateral, the contralateral kidney will take over the function of the abnormal kidney and undergo compensatory hypertrophy. Sonographic findings include a unilateral, smooth-walled, non-communicating series of cysts of varying sizes within the renal fossa, and compensatory hypertrophy of the contralateral kidney. So here we have multicystic dysplastic kidney disease, and we can see unilateral, smooth-walled, non-communicating cyst of varying sizes located within the renal fossa. Acquired renal cystic disease is often the result of chronic hemodialysis, and clinically, patients will present with a history of hemodialysis, and sonographically the kidneys will appear small initially, and with time the kidneys may enlarge and have numerous small cysts noted throughout the renal parenchyma. Von Hippel-Lindau syndrome is an inherited disorder characterized by tumors of the central nervous system and orbits. Patients with this syndrome have the propensity to develop cysts within the kidneys, as well as renal cell carcinoma and pheochromocytomas. Clinical findings are often symptoms of brain and/or eye tumors, and sonographic findings include multiple renal cysts. These cysts may have mural nodules indicating renal cell carcinoma, and the cysts may be within the pancreas. Pheochromocytomas may be present. Tuberous sclerosis is a systemic disorder that leads to the development of tumors within various organs. Clinical findings can include epilepsy and skin lesions to the face. Sonographically, we see bilateral renal cysts and bilateral angiomyolipomas. Acute pyelonephritis. This is an inflammation of the kidney where bacteria can spread into the bloodstream, and this more commonly occurs from lower urinary tract infections. We refer to acute pyelonephritis as an ascending infection, and the infection begins in the bladder and refluxes up through the ureters and into the kidneys, and it's most often encountered in females. Clinically, patients complain of flank pain. There is evidence of bacteriuria, pyuria, leukocytosis, urinary frequency, and dysuria. Sonographically, the kidneys may be normal, there may be some renal enlargement, there are some focal areas of altered echotexture, and there is compression of the renal sinus. So acute renal infection can present with interstitial hemorrhage, and this produces a hypoechoic focal swelling in the upper pole of the kidney. Pyelonephrosis. This describes the condition of having pus, or what we call purulent material within the collecting system of the kidney. And the accumulation of pus is most likely caused by an obstructive process or an infection, and the patient will likely present with pyuria, bacteriuria, fever, flank pain, and leukocytosis. Sonographically, the patient will have hydronephrosis, and pus and debris as internal layering and low-level echoes within the dilated collecting system. As we can see here, the dilated collecting system shows these internal layering low-level echoes. Chronic pyelonephritis occurs through recurrent kidney infections and chronic obstruction, and this leads to scarring of the calyces and scarring of the renal pelvis. Chronic pyelonephritis can lead to xanthogranulomatous pyelonephritis and end-stage disease. Patients present with flank pain, bacteriuria, pyuria, and urinary frequency. Sonographically, we see small echogenic kidneys that have lobulated borders, and the renal scar is quite apparent, and the renal scar appears as an echogenic area within the kidney that extends from the renal sinus through the renal parenchyma. So here in this image we have a small echogenic left kidney with a dilated calyx and overlying parenchyma atrophy. Perinephric abscesses. These are renal abscesses that can occur in regions of a kidney affected by pyelonephritis. Sonographically, we see anechoic or complex structures. We can see gas shadows or dirty shadowing. Epenzematous pyelonephritis. This is a rare and life-threatening complication of pyelonephritis. And the term ensevematous denotes the formation of air within the organ. So consequently, bacterial formation allows gas to accumulate within the renal parenchyma, and the bacteria that causes this most often is Escherichia coli or E. coli. These patients present with diabetes mellitus and they might be immunocompromised. So in epenzematous pyelonephritis, we see gas or air within the renal parenchyma, as well as dirty shadowing or reverberation artifacts. Xanthogranulomatous pyelonephritis is uncommon and is typically caused by chronic urinary tract obstruction, and the word xantho means yellow. Clinically, patients may present with dull or persistent flank pain, but sonographically we see staghorn calculus, perinephric fluid collection, and hydronephrosis. Renal fungal disease. The most common cause of fungal urinary tract infections is Candida albicans, and this usually comes about due to the immunocompromised state of certain patients. Sonographically, we see fungal balls, and these fungal balls are hyperechoic. They are non-shadowing mobile structures within the renal collecting system. Next, we can move on to glomerulonephritis. This can be caused by a distant infection such as strep throat or an autoimmune reaction. Some conditions such as lupus may have glomerulonephritis as a characteristic feature, and it is a result of a long-standing infection that leads to end-stage renal disease. So sonographically, the kidneys are enlarged, demonstrate increased echogenicity, they're prominent renal pyramids. This is in the case of acute, and when it becomes chronic, the kidneys become small and echogenic. Parasitic urinary tract infections. And the most common parasitic infection in this case is schistosomiasis, which is a round worm. As sonographically, schistosomiasis is most often seen in the bladder, and it's caused by, or rather its visualization is due to thickening of a gallbladder wall. Sonographically, the renal cyst depends on its stage of maturation, and it may appear completely anechoic or contain a daughter cyst with internal debris, or as a complex mass with calcifications. So sonographically, in schistosomiasis, we'll see bladder wall thickening. But there can also be cases of Echinococcus granulosus causing hydatid cysts. And depending on the stage of its maturation, we may see completely anechoic cysts that have daughter cysts and internal debris, or complex masses with calcifications. Urinary tract obstructions. So we can see urinary tract obstructions as having intrinsic and extrinsic causes. So intrinsically, we can have a urolith, we can have vesicoureteral reflux, there can be hematoma or a neoplasm. And extrinsically, we can have a benign prostatic hypertrophic prostate. There can be a neurogenic bladder or retroperitoneal fibrosis. And in the case of urinary tract obstruction, you can see moderate hydronephrosis in the urine-filled dilated renal pelvis. Urolithiasis, these are kidney stones located anywhere within the urinary tract. When seen, the kidney stones will be echogenic and may produce posterior shadowing. And the sonographic sign is a twinkle artifact, and it will be noted as increased color Doppler signal posterior to a kidney stone. A urolithiasis that becomes lodged within a distal ureter may be better imaged with an endocavitary scan. Clinical findings of urolithiasis include hematuria, renal colic, oliguria, or UTI. Sonographically, we see echogenic foci that produce acoustic shadowing. We see a twinkle sign, and we see hydronephrosis and a dilated ureter. The twinkle sign will be seen posterior to the stone with the use of color Doppler. Nephrocalcinosis and medullary sponge kidney. Nephrocalcinosis is the accumulation of calcium within the renal parenchyma. There are two forms. There's medullary nephrocalcinosis and cortical nephrocalcinosis. Although medullary nephrocalcinosis is commonly caused by hyperparathyroidism and associated with hypercalcemia, it can also be congenital. Medullary sponge kidney is the accumulation of calcium within the abnormally dilated collecting ducts in the medulla. Clinically, patients may have hypercalcemia, hyperparathyroidism, UTI, or urinary calculi. Sonographically, we see echogenic renal pyramids in the cases of medullary sponge kidney, and in cases of cortical nephrocalcinosis, we see echogenic foci within the cortex. Here is a case of medullary nephrocalcinosis, and we can see echogenic foci within the renal pyramids. Angiomyolipomas are the most common benign renal tumors, and they consist of a network of blood vessels, muscles, and fat, and they may be referred to as renal hematomas. Sonographically, we see solid hypoechoic masses that may produce acoustic shadowing, and they tend to be multiple and bilateral with tuberous sclerosis. Oncocytomas are benign renal cell tumors, often found in men in their 60s, and it is the second most common renal mass after the angiomyolipoma. Sonographically, we see isoechoic, hypoechoic, or hypoechoic masses, and they may contain central scars. Renal hemangiomas, these are masses or blood vessels, and they're most often asymptomatic. And sonographically, we see small hypoechoic masses. Renal lipomas, these are benign fatty tumors, and we see these as well circumscribed hypoechoic renal masses. Renal adenomas, these are benign masses that appear similar to renal cell carcinomas. And we see hyperechoic vascular masses with internal calcifications. They may produce acoustic shadowing. Renal hematomas, these are localized collections of blood, and they may be variable in appearance depending on the stage of the blood and location. Blood may accumulate under the capsule, being subcapsular, in the perinephric area, such as gyrota fascia, the paraneural area, anterior and posterior, or intramuscular, in the psoas muscle. Chronic hematomas may calcify and produce acoustic shadowing. Renal cell carcinomas may also be referred to as hypernephromas and adenocarcinomas of the kidney. These are primary renal cell cancers. Sonographically, we see hypoechoic, isoechoic, or hypoechoic solid masses in the kidney with complex cystic appearances. Renal cell transitional carcinomas are malignant tumors that are often found in the renal pelvis. We see hypoechoic masses within the renal sinus and varying degrees of hydronephrosis. Metastases to the kidney, these are often from the lungs, the breast, the prostate, or the pancreas, and they may be bilateral, or we can have lymphoma and leukemia manifesting together with enlarged kidney. Metastases have varying sonographic findings but are most often solid tumors. So we can have renal vascular abnormalities. So Nutcracker syndrome is compression or entrapment of the left renal vein as it passes between the superior mesenteric artery and the abdominal aorta. And the left renal vein will reveal elevated pressure upon Doppler, and patients with Nutcracker syndrome can present with flank pain. We can have renal vein thrombosis. This is a blood clot within the renal vein, and we would see an heterogeneous renal echotexture, an enlarged renal vein, and absent renal vein Doppler signals. The thrombus may or may not be seen. So here we have a spectral Doppler waveform from a segmental renal artery, and it demonstrates reversed diastolic flow. There is your reversed diastolic flow. So renal biopsy is often the best indicator of renal transplant rejection, and a transplanted kidney, referred to as an allograft, is placed within the right or left lower quadrant. So we use Doppler to warrant full function of the transplanted kidney, and so the renal vein should demonstrate continuous flow away from the kidney, and it may be examined at the anastomosis site with the iliac vein. Congenital hydronephrosis can occur as a result of several conditions, but the most common is vesico-ureteric reflux. And this vesico-ureterial reflux can occur due to ureteral pelvic junction obstruction. So we can move on to pediatric vesico-ureterial reflux. And this is a retrograde flow of urine from the bladder to the urethra. So clinically, patients may present with UTIs, and patients with minimal reflux may have normal appearing kidneys. But we will generally see hydronephrosis and hydroureter, as well as ureterocells and bladder debris. And here's a good example of vesico-ureterial reflux. You have a ureterocell, and you have your ectopic ureter that is dilated, and there would be some mild form of hydronephrosis seen. And on this transverse sonogram, we can see echogenic foci protruding into the bladder, and these represent what we call the bulking agent effect, or subureteral Teflon injection. That is the medium that was used to examine the bladder. Pediatric Wilms tumor. This is referred to as a nephroblastoma. It is the most common solid malignant pediatric abdominal mass. It is typically discovered before the age of 5 with a mean age of 3, and it presents as large, solid, mostly echogenic masses that may contain anechoic or hypoechoic areas. Urachal abnormalities. These are remnants of embryonic development, and they're tubular structures that extend from the umbilicus to the apex of the gallbladder. A patent urachus will appear as an anechoic tube extending from the umbilicus to the apex of the urinary bladder. Urachal cysts and diverticuli will appear as cystic structures between the bladder and the umbilicus. Urachal sinuses will appear as linear fluid-filled structures continuous with umbilicus. And the ureters are bilateral muscular tubes extending from the renal pelvis to the renal bladder, and the most proximal portion of the ureter is at the point at which the ureter is attached to the renal pelvis. This is referred to as the uretropelvic junction. The point at which the ureter meets the urinary bladder is the uretrovesicular junction. Normal ureters are not routinely imaged with sonography due to their small size. However, when enlarged and distended, the ureters will appear as anechoic tubular structures. Ureteral stones most commonly become lodged in the uretero-vesicular junction near the urinary bladder, and they appear as echogenic foci within the ureter that produces acoustic shadowing and dilatation of the ureter proximal to the stone. Ureterocells are cystic dilatation of the ureter as it enters the bladder. We see anechoic balloon-like structures within the lumen of the urinary bladder near the uretero-vesicular junction, and in certain cases they can be ectopic. Megaureter and hydroureter, these are based on the cause of enlargement. The ureter may become enlarged or congenitally, known as megaureter, or associated with reflux, and we call this hydroureter. And we would see large anechoic tubular structures extending from the kidney to the urinary bladder, and only one section may be enlarged. So the urinary bladder is a retroperitoneal organ, and it serves as a reservoir of urine. The muscle that controls the emptying of the urinary bladder is known as the detrusor muscle. The trigone of the bladder is located inferiorly at the base of the urinary bladder, and its location marks a single urethral opening and bilateral ureteral openings. Sonographically, the normal urinary bladder appears as a smooth-walled anechoic structure within the pelvis. In the transverse plane, it appears as a square-shaped organ, whereas in sagittal it appears more elliptical. A neurogenic bladder is one that is poorly functioning, second to any type of neurologic disorder, such as brain trauma, spine trauma, and sonographically we see urinary bladder thickening of the wall, trabecularly, and the patient may have a distended bladder without the need to micturate. A bladder diverticulum is an outpouching in the bladder wall, and the diverticulum of the bladder may be associated with a urethral obstruction, or it may be congenital. Sonographically, we see anechoic outpouchings of the bladder wall and a visible neck containing diverticulum in the bladder. Urinary bladder pathology, in this case cystitis, is inflammation of the urinary bladder, and this is where the hypoechoic bladder wall may become focally or diffusely thickened, and it may measure greater than 4 millimeters in thickness, and the bladder may contain echogenic layering material within its lumen. Bladder stones or urolithiasis may be created or become trapped within the urinary bladder, and they appear as echogenic mobile structures that produce posterior acoustic shadowing. Blood clots may also be noted within the urinary bladder. Transitional cell carcinoma of the bladder. Now, these masses must be differentiated from other intraluminary bladder abnormalities such as blood clots. The sonographic appearance of transitional cell carcinoma of the bladder is a smooth all papillary hypoechoic mass that projects into the lumen of the gallbladder. Now a brief of the urethra. The urethra begins at the trigone of the urinary bladder and extends at the urethral orifice. The urethra may be noted during sonographic examination of genital tracts, and a portion of the male urethra is surrounded by the prostate gland. Therefore, enlargement of the gland, often associated with BPH, can lead to compression of the urethra, causing urinary obstruction.